Good. Now let us talk about inguinal ligament and the iliopubic tract. I'm going to take you guys a little bit backward to when we talked about our upper limb. In the upper limb, we remember that at places where you have high mobility at this joint, you have retinaculum. So here you have an extensor retinaculum because it is holding all the extensor muscles together in a band like this. And here you have the flexor retinaculus because all the muscles of the anterior compartment of the forearm are held in this band here before they traverse through the carpal tunnel to get into the hand, right? So because there is high mobility here, the fascia which is covering these muscles, deep fascia, are modified at this level and becomes the flexor retinaculum. And from the flexor retinaculum, it also becomes even more modified to form the palmar aponeurosis. And the reason why we have palmar aponeurosis is because here you have a lot of things that's going on around here. So you need to have a well-modified fascia. The same thing applies to the lower limb. In the lower limb, remember that we say the abdomen, remember, the abdomen drives into the lower limb. Remember that? So the abdomen, structures of the abdomen have relationship to do with the lower limb. So the layers of the abdomen, we have the skin, we have the skin, and then we have the camper fascia, the scapa fascia. Now the scapa fascia is an example of a deep membranous layer of subcutaneous tissue. The deep membranous layer of subcutaneous tissue drives into the lower limb. It drives into the lower limb, especially the thigh, and becomes the fascia lata. You all remember fascia lata, right? Now the fascia lata is an example of a modified fascia. On the lateral side of our thigh, the lateral aspect of our thigh, this fascia lata is remodified to become the iliotibial tract. We all remember the iliotibial tract. Okay. Now, the scapa fascia, which is a deep membranous layer of subcutaneous tissue, drives into the scrotum and becomes a dartos fascia. So they are all the same thing, but because they move from region to region, they begin to change and modify themselves. Now, the inguinal ligament is also a kind of a modification of a fascia. The external oblique muscle, the inferior aspect of the external oblique muscle becomes aponeurotic. Now, I'm going to use this to describe these layers and how the inguinal ligament is formed, as well as the iliopubic tract, not the iliotibial tract. Iliotibial tract is different from iliopubic tract. The iliotibial tract is attached to the lateral aspect of your thigh, runs from the lateral aspect of your ilium, the iliac crest, and then is attached to the gaudy tubercle of your tibia. Okay, that is why it's called iliotibial tract. Now, this is called the iliopubic tract. It is seen from the inside, not from the outside. Okay. Now, this is our external oblique muscle. The external oblique muscle is not muscle all the way. It is muscle and aponeurosis. That is why it is called the musculoaponeurotic structure. It's a musculoaponeurotic structure. The inferior aspect of the external oblique muscle, curves inwardly like this. It curves inwardly like this, and it runs from the anterior superior iliac spine to the pubic tubercle, and it curves inwardly this way, forming something that looks like a gutter. I can actually put something inside and it will stay, right? This portion of your external oblique muscle is aponeurotic. It is not muscular, it is aponeurotic, okay? So that is your inguinal ligament. The inguinal ligament here, this gutter aspect here, this thing here, forms the anterior wall of your inguinal canal, which we will be talking about in a short while. But I want us to understand the difference between the inguinal ligament and the iliopubic tract. Now, this here is the next layer is my internal abdominal muscle, the internal oblique muscle, the internal oblique muscle. Now this is my transversus abdominis muscle, and this is my fascia, the transversalis fascia. All right, so from superficial to deep, I have these four structures that are forming your anterior abdominal wall. Okay, now this is the external oblique, which forms the gutter, which forms your inguinal ligament, and this is the internal oblique muscle, and this is the internal oblique, and this is the transversalis fascia, the transversus abdominis muscle. Now, in the inferior aspect of your these two muscles are separated superiorly, but they join together inferiorly to form a conjoined ligament. We also call it the falx inguinalis. The falx inguinalis, or a conjoined tendon. It forms a conjoined tendon, and the conjoined tendon attaches to the pubic tubercle inside. So this is inside the conjoined ligament. Okay? And then finally, we have the transversalis fascia. The transversalis fascia becomes very thick from the inside. So it becomes very thick from the inside, and that forms your iliopubic tract. Your iliopubic tract is the opposite of your inguinal ligament when you look at it from a laparoscopic view.